host, Nick Jikomis, and today I'm speaking with Dr. Jay Bhattacharya. Jay is a professor of medicine, as well as a professor of economics and in health research and policy at Stanford University. He has a MD as well as a PhD, but he has spent his career as a researcher. His expertise is primarily in the general area of infectious disease epidemiology and public health and public policy. Jay has been very active in sort of discussing publicly different aspects of the COVID-19 pandemic. So we talked about different aspects of the pandemic. I talked to him about how infectious, transmissible, and deadly COVID is and how our knowledge of those things has changed over time from the beginning of the pandemic to the present moment. We talked about things like natural immunity versus vaccine-induced immunity and whether or not the strength of your immune response will be different depending on if you've got one or both of those. We talked about the mRNA vaccines that were developed for COVID, a little bit about how they work and how they were implemented. We talked about what we know in terms of, whether or not these vaccines are preventing severe illness versus transmissibility and what that means. We talked about what's known today about any potential negative side effects from the vaccines. So we got into a short discussion about myocarditis rates in men versus women and younger versus older individuals. We talked about the evolution of novel COVID variants and how that plays into all of this. We talked about things like masking, what we knew about masking early on in the pandemic and what we know today, how effective really are cloth masks versus N95 masks, and what does all of that mean? And we got into a discussion around the institution of science and free speech. Some of it centered around the fact that Jay was personally named in some of the recent Twitter files, information dumps that happened on Twitter. Jay's account was actually specifically not suspended, but suppressed in certain ways over the last year or so because of who he is and some of the stances he's taken with respect to COVID policy in the US. So his account was actually suppressed and his tweets were prevented from being boosted in certain ways on Twitter. And so we talked about that. We talked about his recent trip to Twitter headquarters and what it was like meeting Elon Musk and what he thinks about him. We talked about the public perception of experts and scientific authorities at places like the NIH and the public health institutions of the US, the relationship between science and the public and what's been going on with the public's trust in science. We talked about, his sort of bird's eye view of how he thought the US handled the pandemic compared to other countries, what he thinks about lockdowns versus focused protection strategies for mitigating things like a viral pandemic like this. And all of those topics obviously interrelate, and we got into all of them a fair amount. So if you're interested in COVID-19 and understanding, whether or not our response to it was effective or could have been done better, the understanding things like how well or how poorly masks work at actually protecting you from transmission, and things related to the vaccines and what they do and what they don't do, this will be an interesting episode for you. It's also interesting from the perspective of, just thinking about issues like free speech and, the public discussion and debates that people like to have around scientific issues as they relate to public policy, specifically in the context of COVID. So we touch on all of those things. As always, if you enjoy the content I am producing here, please like, share, and subscribe wherever you are listening or watching. This introduction will be on YouTube, but the full episode will not go onto YouTube. I had a previous discussion with the epidemiologist Martin Koldorf actually pulled down for YouTube. They said it violated some of their policies, but they were not able to tell me specifically what piece of content inside of that conversation actually violated those policies, and I could not tell that anything did. So because we're talking about the subject, and for better or worse, because all of these subjects are fairly controversial, I decided not to put the full episode on YouTube, but there are links in the episode description where you can get access to the full audio and video versions. This episode is supported in part by Athletic Greens. Their main product, AG1, is a comprehensive and convenient daily nutrition product containing 75 vitamins, minerals, and whole food-sourced ingredients with less than 1 gram of sugar per serving, no nasty chemicals or artificial anything. It's gluten and dairy-free and compatible with paleo, vegan, vegetarian, and ketogenic diets. AG1 is a quick and convenient way to supplement your diet to help ensure your body is getting the nutrients it needs. It comes in powder form, and you can mix mix it in water and drink it, or you can put it into a smoothie or a shake or something like that. I mix it into water and drink it with the first meal of each day, and it's super convenient. If you go to athleticgreens.com/mindandmatter, Athletic Greens will give you a free 1-year supply of vitamin D and 5 free travel packs with your first purchase. Their vitamin D product comes in tincture form, so you just take 1 drop each day. A large fraction of the population is actually vitamin D deficient, especially in winter months when we get less sun exposure. And vitamin D is super important for the proper function of the immune system and for a variety of other things. And there's even evidence indicating that vitamin D deficiency is correlated with more severe cases of COVID-19 in those who get infected. Every time I go into the doctor each year for a checkup, I'm always told that vitamin D deficiency is very common and I should be supplementing on a daily basis. So visit athleticgreens.com/mindandmatter or click the link in the episode description. You'll get a free 1-year supply of vitamin D with your first purchase. And with that, here's my conversation with Dr. Jay Bhattacharya. Can you tell, for people that don't know you already, a little bit about your scientific background and what you do?
Sure. I have an MD and a PhD in economics. I have been a professor in the School of Medicine at Stanford for about since 2001. And before that, I was a scientist at the RAND Corporation. I've been studying infectious disease epidemiology and policy since like 1998. My first papers were on HIV and HIV policy. I worked on H1N1, published peer-reviewed papers on H1N1, on antibiotic resistance, a whole bunch of papers. I do a whole range of issues in addition to that, but that's been a major thread of my work for most of my professional life. I work also with the FDA on vaccine safety. I was one of the helped set up their system, the system called BEST, to do epidemiologic surveillance studies of vaccine and biologic safety. So I've had a lot of experience working in these areas for over the last couple of decades.
Interesting, and we're going to spend a lot of our time here talking about COVID-related issues, and so. You've obviously thought a lot about this, and I want to kind of start out with some questions for people around what we know today and how our knowledge evolved in the past 2 years around how infectious, transmissible, and deadly COVID is across different cohorts of the population and based on immune status and things. So if we rewind the clock and go back to early pandemic days, 2020, 2021, what did we know at that time about how infectious, transmissible, and deadly this virus was, and how has our knowledge changed around that over the past couple of years?
Sure. So why don't we take those in turn? So first with transmissibility, like how is the virus transmitted? I think in the early days of the pandemic, I don't think people really had any firm idea about that. There were pieces of evidence that had come out very early on that should have given indications that the disease was airborne and that it spread via aerosols. If I remember, there's very early on a report from I think it was a Chinese restaurant in China, where one patron got it at one end of the restaurant. There was a fan blowing or something, and then some patron completely in another party on the other side of the restaurant then got it also. So, I mean, that should have indicated that the disease was airborne. I think part of what the thinking was happening back then was that SARS-1 probably was spread more by fomites. It wasn't fomites, meaning you spread it by you touch a surface that has it on. I spit. The thing stops on the surface. I touch my eyes, and now I've got it. SARS-1 wasn't particularly good at transmitting from human to human. So I think in the back of some people's heads, especially prominent public health folks in places like the World Health Organization, they thought this might be like SARS-1, that it didn't spread all that efficiently, and you looked at the Chinese example in January 2020. They did the draconian lockdown in Wuhan, but it looked like the disease went away. Well, if it's airborne, it just spreads by aerosol. How can that be? It must have been, people thought, spread more by fomites or other droplets or some other less highly infectious kind of mechanism. And so the WHO, I think, famously put out a statement saying it's not airborne. It was remarkable, actually, because it wasn't at all clear back then that was the case. Okay, so transmissibility. What do we know? Oh, what do we know now? We know it's airborne. We absolutely 100% know now that it is spread by aerosols. Aerosols are like clouds. They stay in the air. They defy. It seems like they defy physics. You're not thinking too carefully about the physics of it. So you have virions that'll sit in the room. If I had COVID and I'm sitting in this room with very poor ventilation, it'll sit in the room for a long time, and someone else could come in and get it.
You breathe it in.
Yeah. So I think that's the primary way it goes. It may still spread. I mean, it may have some spread by droplets and fomites, but I think that is not the primary mode of transmission.
And so what about infectivity? Like, how infectious is this respiratory virus compared to, other respiratory viruses that people may be familiar with?
So if you have an unvaccinated population with measles, it's incredibly infectious. You are in the presence of someone with measles for a short period of time, and you can get it pretty quickly. On the other hand, something like turns out like leprosy is not all that infectious. You can be sitting in the same room with someone. When I was a medical student, I actually worked in rural India in this clinic with treating Hansen's disease. They had like every month they would come to the clinic. And they would meaning the patients with Hansen's disease, leprosy, would come to the clinic, and they would get this whole slew of antibiotics that were provided by the World Health Organization. And what the doctors who were my preceptors were telling me is that I could sit in that room. I was healthy, young, healthy. I'm not going to get it. They don't really know how it transmits, but it's you have to be in sustained contact in environments where it's not particularly sanitary for a long period of time in order for it to transmit. This is somewhere between measles and that, I'd say. I got COVID in August of 2021, and my family, I didn't isolate with my family. I didn't wear masks. I slept in the same bed with my wife. My kids were all around me, and they didn't get COVID. I think that you can get now. On the other hand, Omicron seems to be much more infectious, so that less time in the presence of someone breathing near someone with Omicron is more likely to transmit. There was some questions about like whether viral load in the nose correlates with transmissibility, and I think I think it's complicated. Right. So for children, it seems like the literature suggests that if you have a high viral load in the nose, it's still children are not particularly good at transmitting this disease for reasons at least I don't fully understand. I'm not even fully. I just don't understand. Children seem less. They're not for the same viral load, the same amount of time around a kid. They seem less likely to pass the disease on than an adult with it. So transmissibility, I think, has changed during the pandemic. Early on, less transmissible. Now, a lot more with the Omicron variant.
So yeah, there's this interesting question around some age differences here. So there may be differences between the young and old in terms of how easily they're infected or transmit the disease. There's also, as many people know at this point, a huge difference in your susceptibility to getting severe COVID and dying from COVID depending on your age. How early in the pandemic were we aware of that age-dependent effect in terms of the deadliness specifically?
The deadliness of the disease, the age gradient and the deadliness of the disease was apparent from the very earliest days of the pandemic. If you looked at the Chinese data, it was older people that were dying. If you looked at the Diamond Princess, that cruise ship that went around with so many people infected, it was the oldest people that were dying. By the way, the Diamond Princess was interesting because there was no isolation possible, but only like 60-70% of the ship got the disease. So it wasn't, the transmission. There was a hint about transmissibility even there, but in terms of who was dying from it, it was the oldest people. Has always been that. Martin Kulldorff famously wrote a piece in that he tried to get published, just documenting from I think from the Chinese data, the age gradient in mortality. And he couldn't get it published. He ended up putting it in his LinkedIn blog just to have a marker that people couldn't tell from early on in the pandemic that there was this age gradient. So we knew that from the early stage of the pandemic, that the highest risk people were older, and the children were at very, very, very low risk. It's not that children can't get it and die from it. That's obviously false. They can. It's just that relative to other risks in their lives, including other respiratory virus risks, it's on that same order or lower.
And I recall fairly early on in the pandemic, there's a lot of uncertainty. Obviously, people were scared and anxious for all sorts of reasons, but there was some controversy around this thing called the IFR, and how the infection fatality rate or ratio. And some people were saying it was known and it was one thing. Some people were saying it was unknown. We don't know what it is yet. And there were a range of opinions from different people out there in different organizations. What did we know early on, and what do we know today about what this number, this IFR, actually is for this virus?
Okay, so I actually played a pretty prominent role in that story, Nick. Because in March of 2020, I wrote a piece in the Wall Street Journal. It was the first op-ed I ever wrote in my life. That was with an analysis of data from the Diamond Princess and from the NBA of all places. And just to give some sense of what are the range of estimates that are possible for the infection fatality rate. And so just the audience knows that there's two distinct ideas, measures of fatality risk in infectious disease epidemiology in this kind of context. One is the case fatality rate, CFR. Case fatality rate has, in its denominator, it has the number of people who become cases. A case in this case means you showed up at the doctor, and the doctor diagnosed you with the thing, or you showed up in the hospitals, or you somehow showed up in the morgue even, and they diagnosed you with the thing. And the numerator then is the number of people died among the cases. The IFR has the same numerator, but it has as the denominator, it has all of the people that were infected, whether or not they showed up at the doctor, whether or not even they knew that they had the disease. So the IFR, the denominator, is much larger, or potentially much larger. It's larger than the CFR. The CFR then will be a high estimate of the actual fatality risk, because in order to show up in the CFR statistic, you have to still show up at the doctor. If you have a mild illness, you don't show up in the doctor, you don't get counted in the denominator. That's an overestimate of the risk for the typical person getting infected. In the early days of the pandemic, the CFR estimates that the World Health Organization put out was something like 3-4%. And I remember seeing those estimates, and I thought to myself, because that those have to be overestimates. This is very highly transmissible. If it's true that there are many people who get this that don't have very severe illness, that there's a range of clinical presentations, with the severe pneumonia being only at the tip of the iceberg, then we're really, that estimate is a bad overestimate of the actual risk. This happened, by the way, it's not theoretical. It just happened with H1N1 in the 2009 epidemic. The early estimates of the CFR were like very high, 3, 4, 5%. And people were very scared about that. What happened with H1N1 was there was a series of studies called seroprevalence studies, sero meaning blood, prevalence meaning how common it is in populations, to check what fraction of the population in different countries and different locations had antibodies that were specific to the H1N1 virus, flu virus, and then measure the infection fatality rate rather than the case fatality rate. And in that case, what they found was that there were 100 or more times infections than cases. For every case that was identified, there were 100 people floating around that had the disease and didn't know it. There was evidence of it because they had antibodies in their bloodstream. And so the CFR, though, was 3, 4, 5% early on, was actually, the IFR turned out to be 0.01%, 99.99% survival. rather than 97% survival, an enormous difference. And that basically defanged the H1N1 epidemic. It went from this huge thing that everyone was like worried about, although they didn't lock down then, to much less worrisome, and it sort of it basically defanged the worry around the pandemic. I had that same hypothesis. I had that hypothesis in the early days of the pandemic. What if this disease was more widespread than we knew? And so I wrote this op-ed in the Wall Street Journal calling for a study, a seroprevalence study, to be done as rapidly as possible to measure the IFR.
How rapidly can those be done?
We did it in 3 weeks.
Okay.
So I wrote the study. I wrote the op-ed in March of 20. I think it was March 20th, 2020, 24th, 2020. And by April 4th, we were in the field measuring antibody rates in Santa Clara County. The week after that, we were in the field measuring antibody rates in LA County with a sister study. I actually was surprised that it fell to me and my groups to do this. I thought that the CDC would do these studies.
Just naturally, they would have been doing them already.
Yeah. So this is why one of the reasons I wrote that op-ed is because I was surprised that the CDC had not already done the study. We were in the middle of a lockdown. They'd done this lockdown without knowing how widespread the disease was. It shocked me. It was a basic piece of information that we needed to know to make good decisions. And it's not that complicated or hard to run these studies. So in one sense, especially if you have the resources of the CDC. We ran this study, and what we found was that in Santa Clara County, there's something like 40 or 50 times more infections than cases. That when you adjust for the fact that there's a lag in like when you get the disease from when you die from it, that the infection fatality rate was actually something like 0.2%, 99.8% survival. Now, we were doing this in the middle of a lockdown, so there were some limitations in the study. The most important one is that we weren't allowed to go measure seroprevalence in nursing homes. So we were doing a community study, not nursing homes. Of course, nursing homes were where most of the deaths were. So we didn't have a visibility into that. So the 0.2% is the infection fatality rate in the community at large. It's likely higher in nursing homes. The second thing, the limitation, is the sampling scheme we used was a Facebook sampling scheme. We contacted people randomly by Facebook and asked them to participate in the study. This biased the study toward people who were in the higher income places inside Santa Clara County. Higher income places were better protected because there's more laptop class folks, less exposure. Lower income places like South San Jose, we have fewer people sign up. And so we were biased in the direction of finding people that were higher income and thus lower infection fatality rate. We biased toward it because of that sampling bias. We did an adjustment to try to fix that, based on the demographics of where people signed up. So our estimate, that 0.2%, is representative of the distribution of population within the county based on the demographics. But it's never as good as if you actually have a representative sample directly without doing the grading.
Well, so anyways, you guys did that study at that time, and you get the number that you got. How does that number compare to what we know today? What the IFR is? So
there was now 100 or more of these studies that were done, especially in 2020. They seemed like people were doing it all the time. The median IFR worldwide, according to a meta-analysis by John Ioannidis, is something very close to the number we found. It was like 0.27, something like that. So 0.2, 0.3%, which means 99.8 to 99.7% survival. Younger countries have lower IFR average, which is not surprising. This disease is much more damaging to old people. Older countries have higher IFR. Some places have, especially if they were hit early in 2020, had a higher IFR. So New York had a higher IFR than some other places, not representative of the world at large. But the median among the estimates was something like 0.3%, 0.2%, just exactly what we found in that first study for 2020.
It's 0.2, 0.3%. How does that compare to another virus that people are maybe familiar with, like a flu virus on a typical year or something like that?
So, we don't have excellent IFR data for flus because we don't do these kind of seroprevalences routinely. But the estimate for the flu people would say was something like 0.1%. So it's two times. But on the other hand, the one flu that we did have an excellent estimate for, this H1N1 flu, it was 0.01%. So maybe it's 20 times more. Maybe it's 20 times worse. Ebola, we don't have an IFR, but 30, 40%. I mean, very, very, very high infection fatality rate, I think. So this is worse than the flu, absolutely, but nowhere near in the range of something like Ebola.
I see. Yeah. Okay. That's a good way to think about it, I think. And, another question here around, how serious the illness can be is how bad it is as a function of your immune status. So there's been a lot of discussion and back and forth on this. Can you talk a little bit about the difference between natural immunity and versus people who have mRNA vaccination versus people that have both, one or both or neither of those? How do things like the deadliness and the transmissibility change as a function of your immune status?
Okay, so first of all, I think the key thing is we don't have great data on any of the mRNA vaccines regarding transmissibility and so on, because the randomized trials were like a very short duration, maybe 2 or 3 months, and many of for instance, the Pfizer trial didn't check for transmissibility. Didn't check to see if it protected against transmissibility. They had as its endpoint the prevention of symptomatic infection, which didn't include, for instance, people who had asymptomatic infection, right? So that was the primary endpoint. But so most of what we know is based on by the way, this is also true for natural immunity, but based on epidemiologic data where there's matched cohorts of people that tracked over time. Match meanings like people who had COVID and not had COVID, tracked over time. People who had the vaccine, didn't have the vaccine, tracked over time, observationally, not randomly assigned to each group. I don't know how you randomly assign COVID status. I have no idea. Okay, so based on the best studies of that coming out of places like Qatar, Sweden, Denmark, Kaiser, Northern California, a few other places, what's very clear is that if you had the disease and recovered, Israel, if you had the disease and recovered, you have better protection against reinfection than if you just had the vaccine. The protection against infection lasts for a short period of time, maybe 2, 3, 4 months. After 3 or 4 months, the vaccine efficacy against infection, especially during the Delta wave, dropped pretty precipitously. I think it's even worse during Omicron. And so that means that if you had the vaccine, it's very common to get reinfected, to be infected. So I was vaccinated in April 2021, got infected in August 2021. That is a very typical outcome. 4 months after you get the vaccine, you can get you're again susceptible to infection. The mechanism is not clear, but it may be that there's fewer antibodies. Your antibody production wanes over time and fairly rapidly. On the other hand, and if you look at data from places that track patients who were infected and over a long period of time, the reinfection rate seems to be about 0.3, 0.4%. There's data out of Italy, a whole bunch of places that have tracked people over time that are infected and recovered. So you have very strong reinfection protection if you were infected and recovered. When there's a new variant, the variants evade the ability to protect against reinfection for both natural immunity and the vaccine. And so a lot of people who were infected and recovered before Omicron got infected again during Omicron. Same thing with the vaccines. A lot of people who got the vaccines in April 2021, like me, could get Omicron. In fact, I did. I got Omicron in like a couple months ago. After having had the Delta variant in 2021, I had Omicron in 2022. I had the vaccine and reinfection, and yet I still got Omicron, right? So none of these mechanisms provide guaranteed protection against reinfection, certainly not permanent protection against reinfection. or infection at all. We do not have any mechanism to guarantee that. It's like the other coronaviruses. You've got the other coronaviruses when you were little, almost certainly, and then you've got it again and again and again. Just you can get reinfected, especially as new variants pop up. What we have seen, though, and that's the bad news, Nick. The good news is the reinfection or infection after the first time you've been vaccinated is less likely to produce it's less likely to produce death or hospitalizations than the first time you're infected or if you are unvaccinated and you get the disease. So the vaccines and infection and COVID recovery both provide protection against bad outcomes when you are reinfected.
I see. So even if you get reinfected with a new variant, so the new variants can escape the immunity that you get from having a prior natural infection or escape the immune modulations you've gotten from getting an mRNA vaccine. So you can still get reinfected. But even if it's a reinfection with a new variant, your chances of getting severe illness that requires hospitalization is lower, whether or not it's an mRNA vaccine induced or a natural induced immunity.
Yeah, that seems to be clear from the epidemiological data. Not so much from the randomized trials. The randomized trials actually didn't show that about the mRNAs. The randomized trials actually had no statistically significant difference in the mortality risk from infection for the placebo versus the vaccinated group. In fact, it was slightly higher in the vaccinated group for the all-cause mortality. So yeah, but I think that the data that came out of the epidemiological studies afterwards show exactly what you just said, Nick.
And do we know? So let's say you get reinfected. One person gets reinfected and they have not had COVID before. They have had at least 2 doses of the mRNA vaccines. Another set of people gets infected and they've had a natural infection previously. Is the immune response from each group of people going to be comparable, or is it going to differ in any way? Is each group going to produce a different set of antibodies and cellular immune responses? What do we know and what do we expect there in terms of similarity and difference?
So that literature is still developing. So that it sometimes goes under the name of original antigenic sin, or it's not exactly OAS, but like that's what people sometimes call it. Or like you're essentially, the idea is that your immune system is trained by the initial exposure to the antigen that you see, the version of the antigen you see. So if you saw Omicron first, your immune system is sort of primed to deal with Omicron-like spike proteins or whatever. Whereas if you saw the vaccine, the original vaccine, which is basically Wuhan, the Wuhan version of the spike protein, then you're trained to deal with that. And there is some evidence that that's true. I haven't decided yet. I don't think that literature, at least up to my satisfaction, is ripe enough for me to say with any certainty one way or the other about that. I don't think I've seen the epidemiological data, anything that convinces me to worry so much about that, because people who'd had COVID before and recovered with Delta, they're less likely to die from Omicron than someone who's completely immune naive, holding other things fixed. Which means that and you had the vaccine, the Wuhan A vaccine, essentially. The Wuhan vaccine, the vaccine trained on the Wuhan spike variant, and that seems to provide good protection against severe disease, even against other variants. So the key thing to me is not I think a lot of people get mixed up on this because they're like thinking about infection blocking. There may be OAS around infection blocking. Again, I haven't fully decided this, but the key thing to me is, does it provide protection? Does prior immunity, either by the vaccine or by COVID recovery, provide current protection against severe disease, even against new variants? Seems like it does. That may wane over time. I don't know. I'm not certain. I think the people who've had hybrid immunity, who'd had the vaccine and then recovered, or vice versa, or the other order, either way, seems to have pretty good protection against, when they're reinfected, severe disease. And so I think if I had to rank, probably like hybrid immunity, straight natural immunity from COVID recovery, and then straight vaccine immunity in terms of like protection against severe disease, but they're all really close. So the marginal benefit of, say, getting vaccinated after you've COVID recovered is small relative to if you have the marginal benefit if you're entirely immune naive.
Mm-hmm. And so so the fact that the mRNA vaccines, they contain mRNA for the spike protein of the virus specifically, how does that start to factor into some of this in terms of the magnitude of the immune response that the vaccines are going to induce? And does this play into, in any way, the evolution of new variants and how they evolve?
Okay, so now we're getting an area that's outside of exactly my expertise. So please forgive if the audience is listening. Please forgive me. This is now my totally ignorant understanding of it. But since you asked, I'll try to tell you what I think. So I think the spike protein, that's the epitopes that you get if you are vaccinated. Of course, the virus itself has many other proteins, including this N protein, which induces a response when you're infected. There is some literature suggests that the antibodies to the N protein, let's say you're vaccinated and then you're infected, the antibodies you get to the N protein and the immune training you get to the N protein from that infection is less sort of imprinted than if you just got COVID first without the vaccine. You get COVID first without the vaccine, you get a broad range of responses to the S protein, the N protein, a whole shebang, right? Whereas if you got the vaccine first, just the spike protein, you're primed for the spike protein, you get the whole vaccine then, whole virus then, and the N protein response is less pronounced if you have it in that order. I think that's true, but I don't think that I've seen any evidence that's convinced me that leads to, let's say, now another infection, that you're going to be more likely to die as a result of it. You still have protected pretty well against severe disease, even if you got the vaccine first, then the disease. So I don't know the upshot of that epidemiologically, other than to say I don't see anything in the data that particularly concerns me about it.
I see. So I guess to summarize this whole part, in your view, vaccine-induced immunity and natural immunity are comparable. There might be minor differences, but they're comparable in terms of their ability to protect you against severe illness. But in either case, they're probably not going to protect you against transmission in the future against a new variant.
Correct. Now you asked me about evolution. Now we're really far afield, Nick. So this is it's fun for me to think about stuff outside of my field, but I'm happy to be corrected on this. But let me just say, I think that we have a very different ecological environment for this virus now than we once did in March of 2020. We now have a very large fraction of the population that's been infected. Like, there was a recent estimate out of Harvard and Stanford suggesting like 94% of the population has been infected and recovered in the United States. That's probably true in India. I know that was true very early, even early on. There was a very large fraction by 2020, early 2021, was infected and recovered. So you have a very different environment that this virus is facing. And now there's a mix of vaccine folks who've had the vaccine and also COVID recovered. The virus, I think, the evolutionary pressure then on the virus has been to produce mutations that evade that immunity. The virus wants to replicate. It wants to survive. And the way it can do so is by evading that immunity, evading the antibodies that neutralize it. And I think Omicron is an example of that. I think that it evades the immunity provided by the vaccines, the Wuhan-based spike vaccines, and the prior immunity from COVID recovery. It doesn't seem to be evolving in a direction of producing more severe disease, or in any case, our immune response to it is such that we remember how to cope with it. We don't, and it makes some sense, right? Because I think a lot of the issues clinically with the virus is that you overreact to it. a lot of the worst outcomes, the severe viral pneumonia was an immune overreaction. Now there are some other things that can happen to you if you get the virus, clotting issues, or same thing with the vaccines. You get myocarditis, and other things. I don't think those are I think those are just uh, uh, essentially they don't actually help the virus replicate. They don't help the virus. There's no pressure, evolutionary pressure, to make the virus react in that way. It's just an unfortunate thing that the virus does that to some people. I don't view that as evolutionarily important in that sense. It's just clinically important. The key evolutionary thing to me is the pressure to evade immunity, because if the virus didn't do that, didn't evolve in that way, it would die out. In that sense, I think it's very similar to the other coronaviruses. The other coronaviruses also have their mRNA viruses. I'm sorry, their RNA viruses. They evolve. They mutate a lot. I mean, that's unlike DNA viruses, which mutate less. And there's less error checking. There's going to be a lot of mutation, as there is with the other human coronaviruses and other coronaviruses that float around. The question is, what is selected for? I think what's selected for is immune evasion, not deadliness.
I see. So, one of the things, I remember back when the mRNA vaccines were first coming out, many people like me at that time were really excited and impressed by this technology, in particular around the programmability of mRNA vaccines as opposed to traditional vaccines, and their potential for, rapid development and iteration. If a new variant comes out or whatever, a new virus, starts spreading through the population, you can, practically overnight go in and change the sequence in the mRNA contained within the vaccines. And, that was a very important strength of this new technology. And some of the initial clinical results seemed to be very compelling, at least what we thought they were. But, in retrospect, some of it seemed a bit confusing. So, early days, people like Anthony Fauci were saying things like, quote, when people are vaccinated, they're not going to get infected. A now sort of famous viral tweet from the CEO of Pfizer, said, quote, excited to share the updated analysis from our phase 3 study with BioNTech. Also showed that our COVID-19 vaccine was 100% effective in preventing COVID-19 in South Africa, 100% exclamation point. So at that time, when those statements were being made, were they mistaken? Were they not thinking about new variants? What exactly were they measuring, in the case of the Pfizer BioNTech studies when they were coming out with those statements, and what was your reaction to them at the time and now?
So, I paid very close attention to the trials that were published in the New England Journal and other places for both Moderna and Pfizer. Let's focus on the Pfizer. In fact, both. It's true for Moderna too. The primary endpoint was prevention of symptomatic infection, and they tracked patients for 2 or 3 months. So, in December of 2020, what we knew is that the vaccines, after let's say after 2 weeks after you're fully vaccinated, would protect very strongly against symptomatic infections for a short while. That we knew. What didn't we know? We didn't know, would that protection last for long? We didn't know whether it would protect against severe disease. As I said, the all-cause mortality actually was higher ultimately in the vaccine group than in the placebo group in the randomized trials for Pfizer. Not statistically significantly different. There was 15 versus. There was no convincing evidence that it protected against all-cause mortality. It wasn't powered for that, so I wasn't so worried about that. And then we didn't know if it prevented infections and transmissions. Given all of that uncertainty, my reaction to this was we should definitely be using the vaccines for focused protection of vulnerable older people. It seemed likely if it protected against symptomatic disease, it probably also protected against death from COVID. And we knew that the mortality risk was so much higher in older people than in young people. And so it's vital to get the vaccines make it available to every older person on the face of the earth. And you could pick a cutoff date. 65, 60, whatever you like, but depending on the vaccine supply. But it was the vital thing was to make sure older people got it. For younger people, it was much less important. Prevention of symptomatic infection is not that important an endpoint for a disease that produces a very, 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 very low infection fatality rate, which is true for young people. So I wrote an op-ed with Sunetra Gupta in December 2020 arguing for using the vaccines for focused protection of older people. The CDC and people like Tony Fauci, they had a very different approach to this evidence. They looked at this evidence and they hoped that it would stop transmission, not on the basis of what was there in the evidence, but on the basis of their hope. There was, I guess that what the Pfizer CEO was reacting to was a small study in South Africa that looked at transmission, but it was a short period of time. And they wanted to be able, and you could see it in the language they used. They would say, look, we need to use this vaccine to stop transmission and achieve herd immunity. By that, what they meant was essentially permanent protection against getting and spreading the disease. But they didn't actually have evidence that the vaccines could do that at that point. They just hoped that it would. And so the strategy they adopted was essentially universal mass vaccination with the vaccine, rather than using the vaccine for focused protection of older people. That then led to calls for vaccine mandates, pressure on people, social ostracization of people that chose not to get the vaccine. It led to a whole host of, I think, incredibly damaging policies, not based on hard scientific data, but rather on a hope that the vaccines would do something that it turned out in retrospect the vaccines didn't actually do.
I see. But it sounds like at the time a lot of those statements were made, the evidence that we had wasn't necessarily ruling out that the vaccines could prevent transmission, but didn't demonstrate that. And we just hoped that was going to be true so much that people just sort of ran with it.
That's exactly what I think happened. Right? They thought that that if it prevented symptomatic infections for 3 months or 2 months, that provides enough basis for saying very strongly, I think overstating really, that the vaccine would stop transmission. In fact, they blurred that distinction in the minds of the public.
Interesting. And, around the mRNA vaccines, especially because this is a new kind of technology, it's a different kind of vaccine than people have used historically. They just work in a fundamentally different way. There's questions about the potential long-term consequences of these vaccines. There's the question of how long does the immunity last, and we've already talked about that a little bit. Then there's the question of, are there any big or little potential negative side effects to these things? And obviously this has also been an area of controversy. On the one hand, we had to move very, very fast early on. And, you don't have time to do a multi-year long-term study in the midst of a rapidly evolving pandemic like we've been living through. On the other hand, this is new technology and some time has passed. So what do we know today about any potential negative side effects that might come from these vaccines? In particular, what do we know about that in terms of how it might vary across different age and sex cohorts?
Okay, so excellent. Can I take that in two parts? Because your preface is super interesting about uncertainty and what you do with it in the midst of a pandemic. I think that's a really important point to think about. And remind me if I don't get to the second part, because that's also very important. Mm-hmm. So the uncertainty, how do you manage that in the midst of a pandemic? You can't expect, like, it's funny, like what in polio, for polio in 1954, Jonas Salk and the March of Dimes folks ran a study of a randomized control study of 1.8 million children in the middle of a deadly pandemic. And they waited and saw what the results were. It took them a year. And that led to the mass adoption of the Salk polio vaccine. Later, they were like, the Savin vaccine turned out to be better for some uses and so on. But like the key thing is that they were very, very careful, even in the middle of a pandemic, to try to get absolutely rock solid clinical evidence about the vaccines they were using, both the safety profiles and the efficacy. Um, in this pandemic, it seemed like we were more panicked than we were during the polio pandemic. Um, we now the data we had was not bad actually in some sense. Like this protection against severe against symptomatic infection is a pretty important endpoint. But I think it was irresponsible in December 2020 to try to think that it would stop transmission when we didn't know that it would. Um, and it was irresponsible in December 2020 because it was outside of what the scientific evidence said. But then it was really irresponsible by July of 2021 when it was abundantly clear that there was that heavily vaccinated countries were seeing big outbreaks. It was too late at that point to make that as a safe assumption. You could make a defensible assumption in December of 2020 but not by July of 2021. And we doubled down on vaccine mandates. We've doubled down on vaccine passports and vaccine and pressure to vaccinate, which I think has had a really negative consequence on vaccine on the confidence that people have in vaccines. Even though the scientific evidence by July of 2021 was so clear that it did not stop that the vaccine doesn't stop transmission. And so I think that in terms of like the uncertainty, what you want to do is there's always a balancing act, right? You have this major danger. There's this danger floating of the disease floating around, but you also need to have some adherence to basic scientific principles, or else you're going to end up having the public stop trusting you, which I think what's had happened during the pandemic. As far as like what we learned about side effects, I think there's still more to learn. But what we learned is already really interesting and important. So first of all, it's become very clear. It wasn't so clear in December 2020, but it's become very clear now, and certainly I think by 2021, that this vaccine causes myocarditis in young men, the inflammation of heart muscle in young men, 15 to 40. I don't know. You can pick some range, lower than that and higher than that. It also causes it in women, but at much lower rates. I don't fully understand the mechanism of it. It's probably the spike protein fragments, but it seems to cause it at higher rates than COVID infection does. The same age groups. So if it's the spike,
okay, so that's actually important. I just want to emphasize that. So it's true that in young men, at least, the rates of myocarditis from the mRNA vaccines are higher than they are from getting COVID.
Yes. Now, and of course, it doesn't prevent you from getting COVID. So like people would say, like try to compare those two as if they were really important. But the question is not actually the relative rates of those. You can't avoid getting COVID. Or at least the vaccine doesn't stop you from avoiding getting COVID. Doesn't stop you from getting COVID. So the question is, should I get vaccinated to prevent myocarditis if I'm a young man? The answer is it doesn't do that. So now you're giving yourself two risks: the myocarditis risk from the vaccine, the myocarditis risk from COVID. Doesn't protect you against that. So the overall risk of myocarditis, if you're vaccinated in your young man, is higher than if you're not vaccinated.
Interesting.
So we've learned that. We've learned also, there was just a study that was just published in early December out of an analysis done by the FDA with a group I actually have worked with in the past, called the FDA BEST. What they do is they have data from Medicare and other healthcare claims records where they track people over time, over long periods of time, Medicare the whole rest of their life. They can match statistically people who were vaccinated and unvaccinated, and then look at various outcomes of concern. What they concluded was that there is a elevated risk of pulmonary embolism for elderly people who take the mRNA vaccine. Published in Vaccines, major peer-reviewed paper out of the FDA. And this was just published in December 2022. There's reports out of Israel that suggest there's higher rates of some cardiac events. There was a very careful reanalysis of the randomized studies by a group that includes one of the senior editors of the BMJ, Peter Doshi, and then the lead author I think is Joe Fryman. What they did is they looked at reports of severe adverse events in the mRNA trials, based on based on a list that was compiled by the WHO to say, okay, this may be associated with these vaccines, and then they for each serious adverse event, they would look at the clinical context of this happening, the potential event happening, and not knowing if the patient was in the placebo group or in the vaccine group, they would assign a jury of docs to look at and say, is this likely vaccine associated? And they would vote. Based on that analysis, they found that there was a 1 in 800 risk of serious adverse events with the mRNA vaccines. Now, the problem was that they don't have like detailed patient information, so they don't have age. They're trying to they just have it based on what Pfizer's publicly released about these patients in the vaccine trial. So what they would like to be able to answer is that risk higher for young people than for old people? We don't know that from the trial because that's not been analyzed. I think that kind of methodology really is really appropriate for asking these kind of questions. And I think Pfizer should release those data so that people can do those reanalyses. So we've learned a lot. The vaccines are not benign. And there's one possibility, which may be, the way the mRNA technology works, if they just use straight unmodified mRNA, you'd actually induce a pretty severe immune reaction. There's a big technological advance that happened in order for this mRNA technology to work, which is they replaced one of the base pairs of the mRNA with the pseudouridine, which reduces the immunogenicity of the mRNA itself. I think that it's made it possible. Like you, was quite excited by the mRNA vaccine technology when I first heard about it, because for exactly the same reason as you. Because then we could use it to like get a vaccine against malaria, against a whole host of diseases that we really have not made a ton of progress against, and we could experiment rapidly with just changing the sequence. But I think it's more complicated than that. And I'm not going to apologize again for not for talking outside my area. This is stuff I read, not my training. But it seems to me that it's not as simple as just programming a computer and you run it and you have hardware. There's some interesting and important interactions that we don't anticipate. Like, I don't think anyone would have anticipated the high rates of mRNA. This mRNA vaccine causes myocarditis in young men.
Mm-hmm.
I don't know why it's higher in young men than in young women. I'd be open to hearing suggestions and hypotheses, but that's something I didn't anticipate.
Yeah.
I don't think I saw anyone anticipate before it came out. There's some complications around this because we don't fully understand the biology around it. And just changing the sequence that we put into the heart of the mRNA vaccine that we're using may actually have other biological effects that we don't anticipate.
Mm-hmm.
The lipid nanoparticles potentially can cause problems. The ones that encase them. And who knows? Like, there's a lot of things that you can only learn, unfortunately, by doing clinical experiments on actual people. The issue is, should we put these kinds of technologies out at scale without having done smaller scale experiments? I think it's irresponsible, even in the midst of a pandemic. I mean, in the context of the polio pandemic in 1954, we slowed down and ran a very large scale trial before we put it out to all of the world's kids. We have to be careful. We shouldn't, just because we've had a lot of scientific success, have any hubris around this. We still have to do the work very carefully to make sure that there are unanticipated things we're not seeing, and take those things seriously. But that's what vaccine safety work is about, right? Is to try to find those things so that we improve the safety of the vaccines that are out there. So I think it's at one level it's a scientific question, but at another level it's a policy and philosophical question. How much risk are we willing to take at population scale?
Yeah. What's your reaction to the fact that these vaccines were very rapidly produced and distributed initially? And, in my mind, one of the whole points of, one of the whole potential upsides of using these so-called programmable mRNA vaccines is as we mentioned before, the ability for rapid iteration. If a new variant comes out, you can update your sequence and get a new version that's specific to the new or emerging variant. And yet, as we've had variant after variant come out, they haven't come out with new versions of the mRNA vaccines as fast as I would have expected. Is that surprising to you? Do you know why that is?
I think the problem is like you can't like you still have to test it in humans, right? So like I saw the FDA approve the BA.4/5 vaccine
Mm-hmm.
in on the basis of mouse evidence and with a surrogate endpoint of boosting antibody production. They're specific to BA.4/5.
Mm-hmm. Was this the kind of infamous study that was in 6 mice?
Yeah, I was like, what is it, 8 mice or whatever? I mean, I actually had 30 mice, but 8 were assigned to the what I could. There's some, but the point is, there's no humans in the study, Nick.
Yeah.
Um, I think it's just irresponsible. It's a new product. It's not, with the flu vaccine, there is mouse studies to check for immunogenicity, but we actually have correlated with those mouse studies strong human evidence going back decades. And especially the safety profiles of those flu vaccines are pretty well understood, and we still track them to check for Guillain-Barré syndrome or whatnot. And it's really low. Here you have a new technology where there are safety signals that are concerning. It's brand new. We don't really know if we replace the mRNA code with will it produce something different or not? Will it produce side effects or not that we didn't expect, and so on? We don't know. We just can't assume that it'll behave just like we do with the flu vaccine, which is a very, very, very different platform and technology. So yeah, I think it's just we just went too fast with this. There's another aspect of this technology. I mean, I said like you, I was super excited about the availability of this technology. It just never occurred. I mean, this is probably the biggest mistake I made the whole pandemic was in March of 2020. I thought there was no way we could get a vaccine in a year. That just seemed outlandish. And so I was really pleasantly surprised when we had it in 9 months. The problem, there's another problem now, and this is looking forward to other future pandemics. Now that we have this technology, I think we found that there's no guarantee that we can update it rapidly. There's no guarantee that it'll have the properties we expect it to have once we actually get it. Like for instance, we expect it to stop transmission and it doesn't. We don't have omniscience around it. We still have to do the experiments, right? But what happens now is that people have overestimated the capacity of this technology to produce perfect vaccines at scale rapidly. The next time there's a pandemic, we'll say, well, why don't we lock down and we get the vaccine until we get the vaccine in 3 months? The availability of this technology will induce lockdowns that will end up causing the same catastrophic harm that they've had to poor people and other vulnerable people, to children worldwide, in the hopes of getting a vaccine rapidly out, for which we have absolutely no guarantee that it'll perform in the way expected for them, that would no guarantee they won't have side effects that we don't anticipate. This vaccine technology is a real advance, but if we treat it the same way we treat other vaccine technologies, you need to have clinical data, high quality clinical data for at least some extended period of time before you can do it at scale. And it should not be an excuse to lock down until, I think a lot of people, or some people at least, thought about the availability of the vaccines as a way out of the lockdowns in 2020. I think linking lockdowns to the availability of vaccines is an enormous mistake. I think it will end up making us think that the lockdowns are less harmful than they actually are, or more wise than they actually are.
Yeah, and when we talk about the harm caused by the lockdown, or the way that we are reacting from a public policy perspective to a pandemic like this, can you talk a little bit about how that's measured, and maybe the concept of excess mortality? Like, how do we actually tell that something like a lockdown or some other policy is causing harm?
Well, so excess mortality is a indirect measure of this because there's lots of things that can cause. So the way excess mortality is measured is you look at mortality rates for different age groups, for instance, in previous years. In this case, before the pandemic, so 2015 to 2019, and then you look at mortality rates now, and you compare them. In excess mortality, now you can do age adjustments or other like technical aspects to it, but that's the key idea. And if you see higher mortality now for any cause versus this for the same age group in 2015 to 2019 or whatever, again, whatever time period you want, that suggests that something has gone on that has killed more people now than before. Now that's an ambiguous signal. It can the deaths from that can come from COVID. It can come from lockdowns. It could even come from vaccine injuries. It could come from other things that are happening have nothing to do with COVID. Right. So it's a signal that tells you something's wrong, but doesn't tell you exactly why that thing is wrong. There's more direct things that you can look at that provide some indication, although not a full accounting. Right. So, for instance, the World Bank and the World Food what's it called? There's a group in the world that tracks hunger around the world. The World Bank suggested that the economic in early like April 2020 suggested the economic dislocation caused by the lockdowns, supply chain disruptions in economic activity would lead to 100 million people, 130 million people being thrown into poverty worldwide. Less than $2 a day of income or less, $2 a day of income or less, as a consequence of the lockdowns. It turns out that something like 100 million people thrown into poverty. When you say supply chain disruptions, it's not benign. It means somebody at the bottom of the supply chain loses their job and they can't feed their family. They might be in some poor country, they can't feed their family, and their family starves. In March of 2021, the UN estimated that 230,000 children had died in South Asia alone as a consequence of the dislocation caused by the economic dislocations caused by the lockdowns and also disruptions in standard immunizations. The lockdowns prevented, because we wanted to keep hospital systems open, we stopped people from getting basic screening measures, including basic cancer screening like breast cancer, colon cancer. People delayed. Now men and women are showing up with late stage cancer that should have been picked up earlier, and they're going to die from it. Another thing which is less well known but it's really important, the social science literature before the pandemic had very strongly documented the importance of schooling on the health of children after they graduate. Turns out that even small disruptions, short disruptions in schooling, a few months, can have long-term consequences on the health because what happens is those kids are less well educated, they're poorer, they are less healthy, and they live less long than they otherwise would, just based on those disruptions alone. So there was a JAMA Pediatrics piece early in the pandemic that estimated that the spring disruptions of schooling in the United States would cost American school kids 5.5 million life years in expectation over their lifetime. So these are like pieces of the puzzle. The problem is like the lockdowns, the effects of them are so myriad, so multidimensional that we're going to be counting the harms for a very long time. There's so much harm that's linked to them that's almost impossible to catalog them in its whole. But the broad pictures are absolutely shocking and absolutely overwhelming. I think every poor person on the face of this earth was harmed by these lockdowns in some way or other. Children, vulnerable people, and the effect will be not just in terms of the economic well-being of them, although that was devastating enough, but also in terms of the health, both psychological and physical, of the entire population.
Well, at this point of the conversation, God help us, I want to talk about masks. Everyone's favorite subject.
Yes.
Obviously there's a wide range of opinions, expert opinions and non-expert opinions about masks. Um, Very early in the pandemic, a lot of people have forgotten this. Initially here in the U.S., at least, a lot of experts and public health institutions were initially telling us, actually, don't worry about masks; they're not that useful. But then, overnight at some point, they said, actually, they are helpful. We were just saying that so that we could conserve supplies for healthcare workers. And then, of course, we went through various cycles of mask mandates and endless debates on masking and all of that. You know, Now, a lot of people experienced a lot of whiplash and anxiety around masks for all sorts of different reasons. But today, what can we say with confidence about the effectiveness of masks in preventing the spread of COVID for both regular cloth versus N95 masks?
Okay, Nick, you want to get kicked off YouTube, I can tell. It's funny because the one time I was kicked off YouTube was a roundtable with the Florida Governor DeSantis, where he asked me about the efficacy of mandated child masking in preventing disease. And I told him a fact, which is that there is no randomized evidence at all, zero randomized evidence that shows that they're not even conducted a randomized trial, cluster randomized trial of masking in children. And that we had no high quality evidence at all to suggest masking would work to protect children. And that video, YouTube censored that video of a sitting governor asking scientific advisors on a scientific question. So let's do this with, I'll try not to get you kicked off, Nick, but
Just say what you know to be true.
So I think the evidence on masking before the pandemic was overwhelming. A number of high quality randomized cluster studies that found that masking was ineffective in protecting people against highly infectious respiratory diseases like the flu. And the settings were included like hospital settings, and that included different types of masks. There's some evidence that N95 masks fitted and worn by trained professionals where they were like, changed, when they got wet and things like that. That might work to some degree. But even those, there was like mixed evidence. In population settings, I don't think there was a single one that actually had a very substantial effect on transmission of the flu. This was the basis, and these were randomized studies. Like there was one study. I'm not even sure how they managed this, but they on the Muslim Hajj, the researchers randomized the tents that people stayed in on this pilgrimage to Mecca that people make. They randomized the tents. Well, some tent got the mask, other tent didn't get the mask, and there was no difference in the flu rates among the two tents. Now the uptake was like 50% or something in the but you force people to try to get masks, you won't necessarily get perfect uptake. So the point is that the evidence on masks never showed, but when we entered the pandemic, that they worked in community settings. Not cloth masks, not surgical masks, nothing. This was the basis for why masks were not recommended early in the pandemic for the population at large, because that's what the pre-existing high-quality evidence showed. I don't know why public health made that switch. But sometime in April 2020, public health decided that masking in the general population was the way to go. I think there was a mistake, partly based on how how people thought transmission worked. People thought transmission worked by droplet spread. Droplets are like rain, aerosols are like clouds, right? So I think masks can actually block droplets. If you sneeze into a mask, there's going to be many fewer droplets that are going to come out than if you don't have a mask. And so people thought, okay, well, physically, it should make some sense that it should work, even though there was this long literature before the pandemic that suggested they don't work very well, even for the flu. And
so to use your analogy, I like what you just said. So droplets are like rain, aerosols are like clouds. Is the idea here that simply because we're talking about aerosolized particles as the mode of transmission here, that those aerosols literally just go through the mask? The holes are just not small enough to trap them.
Yeah, it's not even forget about the mask itself. When you wear a mask and your glasses get fogged up, that's aerosols escaping out the hole, the big fat hole that's right here. or on the side or underneath. You have to actually have it in order to block that is really hard. You have to shave. You can't have a beard and actually have a close fit. You can't. You have to leave a line. It's uncomfortable.
Mm-hmm.
Where if you're actually wearing a fitted N95 respirator properly, and if it gets wet, then the way the N95 respirators work, it's not actually a physical block. You still have holes. There's an electrostatic charge that reduces the transmission of even smaller, very small particles through it. But when it gets wet, that sort of like capacity to block even small particles goes away. And so that's why you have to replace it when it's wet. I mean, being trained to wear an N95 is like you have to do fit testing. It's a complicated thing if you ever had to go through it. To tell the public at large to wear it without any of the fit testing, it just means the aerosols are escaping out the sides.
I see.
So I think so this was vastly oversold. I think at least initially on a mistaken belief that it was mostly droplets that were spreading the disease, and then somehow it didn't matter what the evidence was. Like there was that Danish study that looked at mask wearing and in terms of protection of yourself, right? They randomly assigned surgical masks to one group and no surgical masks to another group, and there was hardly any difference in the rates at which they got COVID. I mean, I think it was statistically, I don't remember, I think it was like statistically insignificant, and the actual absolute risk reduction was almost nothing from wearing surgical masks. There was a Bangladesh mask study where they randomly assigned different villages. Now that study, again, none of these studies had kids in it, so like masking children is based on no randomized evidence. But that study found is that the cloth mask had no statistically significant effect, and the effect size was tiny. The surgical masks had a statistically significant effect, but the effect size was like not 9% of efficacy in terms of like the reduction of risk with a confidence interval from 0 to 18. There have been some reanalyses of those data that suggest that even the statistical significance was overstated. And then there's there was just a recent study out of where was it? I'm like going senile, Nick. I'm sorry. There was another recent randomized study where they compared N95 masks to surgical masks and found no difference in hospital settings for spread of COVID. So the pre-existing mask literature, the randomized mask literature on the flu found no effect. The existing mask literature on COVID, randomized mask literature, finds little to no effect, very little efficacy. Now, if you have a low efficacy thing, let's take it at face value and say it's not zero. Let's say it's some efficacy. Mm-hmm. The problem is recommending at scale is that you have this danger that happens that when, like, let's say someone's high risk of dying if they get COVID. They wear a low efficacy device and they take more risk than they otherwise would. So even though physically the mask is reducing, it has some efficacy, you increase the exposure time.
Yeah.
And so you actually made things worse.
Yeah. It's sort of like, it reminds me of the phenomenon of, people buy like, big trucks or SUVs, but then they become riskier drivers because they feel like they're safer in that kind of thing. It's the same, psychologically, it's the same type of phenomenon, I guess.
Exactly. And early days, we said, wear a cloth mask and go out. And you say like my mask protects you, your mask protects me, but really people felt safe wearing a cloth mask, and so they went out. Sometimes some high risk people went out. Nothing indicates the cloth mask works at all. We probably killed people with those recommendations. So you have like, and if you look at like the mask mandates. You compare places that have them and don't have them. There are these like low quality observational studies that the CDC keeps publishing that show that mask mandates worked in some places. But then when you extend the period outside of just the narrow window the CDC looks at it in, or you introduce a control group, or you like do a more systematic analysis of lots of areas, some of which imposed them or didn't impose them. There's no evidence that I've seen that indicates those mandates did anything to actually fundamentally alter disease transmission or the path of the disease. The disease comes and goes as it will. So I think masking has been a complete disaster for the public health and scientific community. We've vastly overstated the data that there are. In many cases, completely not just overstated, but like completely misrepresented the data that there are, ignored high quality data, emphasized low quality data, and as a result, and worse is it's created these weird political divisions. We've turned mask wearing into a signal of how empathic you are. Like we moralize this piece of cloth. You wear it, you're a good guy. You don't wear it, you're a bad guy. And then the reaction to it is like, screw you. I'm not going to follow your rules. It's essentially created this social division, moralization of this thing, which never should have happened, for a low efficacy for a device that has very low efficacy against the thing we want to prevent. It may even cause more harm than good. It's shocking to watch this happen in real time.
Yeah, and all of this gets into, how all of this feeds into the crisis of trust, basically, that we're in with respect to the public and our public health and our government institutions, and all of the big institutions of society. There's people who will believe what our public health institutions will say without thinking. There's people who will never believe anything they say without thinking, and everything in between. There's sort of no good solidarity in the population of having sort of a healthy, reasonable relationship with our institutions and being able to trust what they're saying and why. And I guess I want to ask you about sort of expertise and credentials and public trust and the relationship between the public and our community of experts in various institutions. So you're a professor at Stanford University, very famous university. You've got an MD, you've got a PhD, you've got all of these credentials. You're officially an expert in some fields. Given your status and the credentials you have, given the way things have gone over the course of the pandemic and just over the course of your life and career, how have you sort of seen the relationship between credentials and expertise, and how and why regular people trust or place trust in authority figures with those credentials? How has all of that evolved over time, and what are your thoughts on what's driving those changes?
Well, I mean, I personally, I've never cared about my credentials all that much. Like, if I have data and logic and reasoning to persuade you, then that's one thing. The fact that I'm at Stanford, on top of that, should add nothing as far as I'm concerned to that. But I mean, in what I've seen during the pandemic has just been this almost this guru worship, right? You find your guru and you listen to them no matter what, even if it's someone who doesn't really presenting solid data. At the worst, I think is the example of this is Tony Fauci. He famously gave an interview where he said something very close to, if you question me, you're not simply questioning a man, you are questioning science itself. If you think about what that means, he essentially has created this idea of science as this clerisy with Tony Fauci as the high pope. It's like an inversion of what happened in the Enlightenment, right? Where the whole purpose of the Enlightenment was to say, look, it doesn't matter what your credentials are. If you see Jupiter move, it moved. So I just don't. I mean, I think that this credential is not that. That's not true that the Enlightenment had eradicated credentialism, and science itself is so large and complicated that it always is going to depend on trust to some extent, and markers of trust to some extent. I can't, even in this conversation, I've made some speculation in areas I don't have a very strong expertise. I think it's fine. I think I'm allowed to do that. It's fun. But I've told you a caveat based on this is not an area where that's directly mine. I think everyone should be able to participate in science, but also everyone should be checked. There is no high pope of science. There is no clerisy in science. And I think this move to like make credentials as like like the whole pandemic, the thing you'd hear, and when almost anyone would speak up that wasn't an epidemiologist is, are you an epidemiologist? As if somehow epidemiologists automatically have the credentials or the knowledge and the wisdom to order all of society. Science involves even people who have no credentials being able to say, look, this is wrong. And if they're right that it's wrong, then we should listen to them. Um, uh, I have to say, like I wrote this document called the Great Barrington Declaration, where there was where we argued that because of this high steep gradient in the age from risk of disease, do focus protection for older people. When we wrote that document, I signed it with Martin Kulldorff of Harvard and Sunetta Gupta of Oxford, so Stanford, Harvard, Oxford. That got a lot of attention because it was Stanford, Harvard, Oxford, right? But the idea itself is a thing that should have got attention. I mean, the idea is the old pandemic plan. That's really the key thing. It's a century of wisdom distilled down to a page of focus protection on vulnerable people. Don't disrupt the lives of people that aren't vulnerable so much, because you'll end up causing more harm than good. That wisdom was a century of respiratory virus pandemic management, successful respiratory virus pandemic management, somewhat successful respiratory virus pandemic management. 4 days after he wrote it, Francis Collins, the head of the NIH, wrote to Tony Fauci, calling the three of us fringe epidemiologists, which is a fantastic term that I'm going to put on my tombstone. And they call for devastating takedown. And that rather than arguing against the facts that we were arguing for on scientific basis, maybe we were wrong, maybe we were right. He wanted a personal attack on us. In fact, he attacked us personally, fringe epidemiologists. He viewed the Great Barrington Declaration as a challenge to his authority rather than to his arguments. That's the reason for what he did. He and Francis Collins and Tony Fauci wanted to create this illusion that there was a consensus, a scientific consensus in favor of the lockdowns that they've been supporting. That wasn't true then. It's not true now either, but it certainly wasn't true then. It was an illusion of consensus they wanted to create because they wanted to act like high popes of science. And the idea of the devastating takedown was essentially to say, look, we have more authority than they do, even though they're at Stanford, Harvard, Oxford. We are the the ones who know. That is not how science works, Nick.
Yeah. And I guess this is the distinction between science as a process versus the science with a capital S that people have been making recently.
Yeah, exactly. Science is a human thing. It's a conversation between people. It's not infallible. What it is a fantastic. Sort of the best way we know as humans to learn about the material world, where we check ourselves. And you and I, we have some disagreement about some scientific idea. And it doesn't matter if you're a Stanford professor or not. You run an experiment, it favors you, Nick. You're right, I'm wrong. That's the way it works. That's how science works. And I'll buy you dinner, and then we'll have another argument, and then do the next experiment. Maybe I'll be right the next time. That's the right way to think about science. Unfortunately, I think the social sort of like significance of science has turned into this like source of oracular truth during the pandemic. And that is dangerous for science. It's dangerous for public health, and it's dangerous for public policy.
And so I guess on this general subject of being able to debate and talk about things openly and discuss things at the level of ideas rather than just deferring to who said them and what official position they're in. I like what you said earlier on, evaluating your ideas rather than the fact that you're at Stanford. That should add nothing to the veracity of your claims. Something that you got a lot of attention for recently was you were named, you were in the so-called Twitter files, one of the episodes of the Twitter files, because for a period of time, I'll let you discuss how long this was and what exactly happened. I don't remember all the details, but your account specifically was suppressed on Twitter in different ways. So can you talk a little bit about what was uncovered there recently, or made public at least, and why was that happening, and what exactly how exactly was your account being suppressed?
So Barry Weiss is a fantastic reporter. She got invited by Elon Musk to look into the Twitter's files regarding regarding its censorship efforts during the pandemic, um, and along with other topics. There's so what I learned, Nick, is that at Twitter there are various tools that you can use to like look to see if people have had people like the status that people have for their files for their account. So for instance, um, my account, if you look at the tool that they have, has a little yellow badge that says I'm on a trends blacklist. Trends blacklist. If you click into those things, you can then see, I actually, Elon invited me to go to Twitter, so this is why I actually got to see my own thing. um, if you click in, you can see the history of that trends blacklist. Now, what is a trends blacklist? A trends blacklist is, it says that that my tweets, can go, and other people that follow me can see them, but it will never get on this like trending kind of status, so that
Yeah.
people outside of my own network can see. It'll never show up in other people's things saying, "Oh, other people like this kind of tweet," right? Or trending, so that a very large fraction of the Twitter sphere sees it.
And why were you designated as being blacklisted?
So I don't know that for certain. What I do know is two things. One is that I was put on that trends blacklist the day I joined Twitter in August of 2021, which is interesting. That day I published a link to the Great Barrington Declaration. That was the most important thing I put on Twitter that day. And then the second thing I know is that, and this is based on a lawsuit that I'm a participant in against the Biden administration by the Missouri and Louisiana Attorney General's office and the New Civil Liberties Alliance. It's a First Amendment lawsuit. What we know from that lawsuit is that there were a dozen federal agencies cooperating closely together to provide instructions in regular contact with big tech, including Twitter. And the content of those instructions included what to censor, what ideas to censor in the name of censoring misinformation, and who to censor. In Twitter, in the Twitter headquarters, what I could see in the tool was that there were multiple people that complained about me the day I joined Twitter, and that led to the trends blacklist. It didn't say who complained. It didn't exactly talk about the process that Twitter used to decide that I deserve to be on this trends blacklist, but it was. It seems very likely, just connecting the dots, that federal agencies, potentially even including the NIH or the CDC, told Twitter about, if not me in particular, the Great Barrington Declaration, the idea of focused protection, or something like that. I also found, I searched on Martin Kulldorff, who's the Harvard professor that signed the Great Barrington, or co-authored the Great Barrington Declaration. He was actually put on a trends blacklist for a while in July of 2020. And when I asked him what was happening then on Twitter, he said that he was posting links to some Swedish data that suggested that opening schools was not harmful to kids or particularly to teachers either. Over and over and over again. He said he was most active during those few short months in July 2020. That's when he was most active on Twitter, posting that because he wanted to help tell people that the scientific evidence did not favor opening schools. And then he was put on a trends blacklist for that. He actually wasn't on a current trends blacklist, although he was 3 times in 2022 was put on a trends blacklist. I still don't know fully the process, but it seems really clear that Twitter could not have been doing this just simply on their own. They just don't have the expertise or frankly the motive. The reason they did this is because they were encouraged by the government to do so.
And so how long were you at Twitter with Elon and the employees there?
Oh, that was fun. I was there. I arrived at like 3 p.m. and then I left around 9. I talked to Elon for an hour. He was very generous with his time. And actually, I talked to some Twitter employees, several of whom were pulled over from Tesla. They were there. It's like Saturday night. They told me that they'd be there until 3. That Elon was there until 3, and then at night that like it was just they were like they actually looked they were having fun. Um, it was like it's like you walk in, there's this like 5-star hotel that's like completely empty. There's just all these engineers huddled around trying to like fix things.
Interesting. What you were only with him for an hour. It's not like you know the guy super well, but given the acquisition of Twitter and the changes that have happened since Elon Musk took over, given what you discovered about yourself in the Twitter files release, given your short interaction with him there, what's your general impression of him? Is he, is he similar to the persona that he puts out there? Is he actually sort of the free speech crusader that he's at least marketing himself to be? Is there some kind of intergalactic 5D chess going on where there's much more than meets the eye? Like what did you make of him compared to his public persona?
I mean, actually, at first, I was actually really impressed by him, Nick. I mean, I think he made a joke about he spent $44 billion to buy Twitter, and he made a joke. Well, look, I could have bought a nice island for the same money. And the reason he bought Twitter, he told me, was because he is absolutely incensed by the censorship, and that he views that censorship by Twitter as incredibly damaging for our civilization. That's what motivated him. I was actually I wanted to know if I could share the information I've been getting from the Twitter engineers about my blacklist and so on. I asked him if I could, and I pointed out that, look, I'm not going to sue, because I think I fully support what Twitter 2.0 is doing in revealing this information. I think it's very healthy for the public to know what happened. But there are a lot of things that potentially could lead to lawsuits. He said, look, he hates the idea of wasting his time sitting in depositions, but if that's what it took to to restore free speech to the world, then it's worth it. I really think he's motivated by these free. Now, there's been like complications with someone doxed his, like, where his family was or something, and then a whole bunch of journalists that he suspended and let back on. So there's like complications. Free speech doesn't mean, to me, you let every single thing go. If you're like threatening somebody, obviously that's not free speech. That's a direct threat, but as a broadly speaking, that's his goal. That's the goal I thought that he told me he had, and I believe him. He wanted to restore the ability for people to disagree with each other, even on positions where the government was saying this is misinformation, on Twitter. And I think that's exactly what he's done. And actually, the other half of it is, like, I think he actually is against lockdowns and has been for the whole pandemic. That became clear when we talked about the harms of the lockdowns. Some of the stuff we discussed, I told him as well there. And I think he's sincerely offended by the idea that lockdowns have harmed so many people, and that if we'd had a free discussion, maybe they wouldn't have happened.
In the wake of the whole public health crisis that we've been living through, and the sort of sociocultural volatility that we have right now around that, and how many mixed feelings there are, and different people believing different things, and and with people like Anthony Fauci retiring soon, sort of with all of that stuff swirling, what are your hopes and predictions about how public health governance in the U.S. evolves in the coming years?
Well, I see one of two directions. Like right now, the public confidence in public health is as low as I've ever seen it. And partly it's almost entirely the fault of public health. Public health has taken on positions that are against what the scientific evidence is saying. That automatically is going to cause a lot of like unhappy. Even if the scientific evidence was saying in favor of what like, say, mask mandates or vaccine mandates or whatever. They weren't, but like if they were, even then they would be controversial, right? Because you're forcing people to do, at risk of their jobs, things that they don't want to do, or that they view as potentially harmful to their kids or whatnot. But the fact that it's based on not on scientific evidence, but on like extrapolations, on ideas that aren't particularly supportable given the evidence, that makes people really distrustful of science, of both scientists, and all, as particularly public health. The other aspect of it is politicization, right? So this is a fact, like 99% of public health practitioners and officials in the United States are on the left. A lot of people on the right feel like their ideas are not represented, respected by public health professionals. Now that may be just perception or fact. I think it's fact, but like that, but let's say even it's just perception. That's a disaster for public health. Public health is not political in the sense that of a politician wins 50% plus one, and now you're a successful politician. Public health has to win over 95% of the people for it to be effective. If it only wins over 40% of the people, it's not effective. In fact, it's an abject failure. Even if it wins 50 plus one, it's an abject failure. Even if it wins 60%, it's an abject failure. Public health has acted far outside of its highest ethical norms. And as a result, a very large number of people no longer trust it. So in order to fix that, you can't just do Band-Aids. You actually have to fundamentally transform public health. So that's a very different kind of, you have to reestablish it with a focus and a mission statement that has science at its core, the ethical treatment of people at its core, and then you have to have reforms of structures that put, essentially like checks and balances so this kind of thing doesn't happen again. It's not enough to say sorry. You actually have to get the processes in place so that if people are going to go around saying I am the science, someone else is there to check them. So whether public health can recover from this depends a lot on what public health does. If it just keeps going the way it has, pretending as if it did everything right during the pandemic, or only a minor problem here and there, it will never be effective again. And every time it tries to do something substantive, it'll be opposed. On the other hand, if the leaders of public health, I think the leadership needs to change, but with the new leaders of public health, whoever they are, work to make sure that the processes and internal structures of public health are reformed, so there's better checks and balances, better grounding in ethics, better grounding in science, and then show the public what those are, involve the public in those decisions. Then we have some chance.
When you say involve the public in those decisions, what exactly do you mean?
I mean, like for instance, local public health directors, right? County directors have turns out tremendous power in the United States to make decisions about the lives of people. They're unelected. Maybe make those into elected bodies. Public health, the CDC is very, very opaque to people. Create a citizen participation group or something. Allow journalists to be embedded inside the CDC. The NIH ostensibly it's a scientific agency. It should be very open to the public, but it redacts huge fractions of these FOIA documents are redacted. It's not national security, and yet they're redacted. You have to make the actions of public health agencies completely transparent to the public. I mean, for instance, it would make it so that you could never tell a noble lie again. You can't. As a public health agency, you say, okay, well, I'm going to try to tell you this. I'll tell you this just to trick you and do something I want you to do, even though it's not true. That destroys trust. If you have the public involved, so that those kinds of actions are transparent, they would never do it. Public health has been entirely opaque, entirely resistant to feedback from the public. If the public health doesn't involve the public, public isn't going to trust it. I would contrast that with, for instance, Swedish public health. It has like 90% of trust of the public. And so they never needed mandates. They never used mandates for the COVID vaccines. Got pretty high uptake despite that, because public health trusts it. The public trusts public health. So I think it's one of these things where we're in a very bad place in American public health. The public doesn't trust us as it shouldn't, because we failed so badly. And the leaders of public health are just doubling down, saying, pretending as if nothing went wrong. The only problem was like those horrible Republicans caused all these problems. Um, even those horrible Republicans, as very sweet people, really do need to be able to trust public health for public health to work. It's something very fundamental needs to change in American public health. The attitude of it is too imperious, too divorced from basic ethics, and too divorced from the scientific data for it to be effective.
And, as far as I can tell, it's not like public health was up in that 90+% range and then COVID happened and deteriorated. It was already not there. Why do you think, even pre-COVID, it wasn't where it needs to be?
I mean, I think there was all that I think that like the set of people that are in public health, my observation like from working in public health is that they've spent most of their lives frustrated that the good ideas they have don't seem to be accepted. So like the obesity epidemic is a good example of this, right? So like eat well, exercise, really strong messages. On the other hand, there were like big successes. It just took a very long time. Like smoking rates in the United States have dropped very, very sharply over a very long period of time. It took a generation of public health efforts, slow, frustrating public health efforts, but still effective because they built trust so that most people understand now that smoking is very, very bad for you. But those efforts are not things that generate, very rapid change. Those efforts are like community efforts where you reach out to groups. You're not demonizing them because they smoke. You're educating them. You build trust over a long period of time. It's not directly political. And even action against tobacco companies, that turned out to be a bipartisan effort in the 90s. So you have to build coalitions. It's a slow thing. I think a lot of the reasons why public health was not trusted in the United States before is because it was seen as overly political, and they were moving to more rapidly than they had before they built the kinds of coalitions in the public that would support them in the ideas they had. An example of this is soda taxes. It turned out to be a partisan thing that a lot of people really didn't want. And some good reason, because like it's a very regressive tax. It ends up it's poorer people that'll pay a higher fraction of their income for things like soda taxes. You have to build coalitions and have ideas that understand who the public health is for the people. If you're imperiously ruling over people, they're not going to like you. You have to be in partnership with them. And I think American public health for too long has not seen itself as partners of the people, but rather over the people, trying to like direct it. I think that's a fundamental problem that led to the distrust before the pandemic, and during the pandemic has just accelerated.
In the wake of everything that we've lived through, seeing how the U.S. handled the pandemic, seeing how other countries handled the pandemic, China, New Zealand, you mentioned Sweden, the full spectrum of what different countries did over the past 2 years. When you have the benefit of hindsight to look back at all of those things, how have some of these different strategies played out? What are can you do like a compare and contrast to some of the major differences between some of the countries that handled this in different ways and what you think worked best?
Sure. I mean, it's complicated because I don't think any country did it perfectly. So for instance, the Swedish response, which I admire in many ways, very early in the pandemic was actually a failure. Like what happened was that they did not protect their nursing homes in Stockholm, especially very well, because they didn't employ the principle of focused protection. The idea would be to protect older people, right? That's who's most vulnerable. So they made the same mistake that Andrew Cuomo made in New York, or we made in Michigan or Pennsylvania, where we sent COVID-infected patients back to nursing homes because the idea was protecting hospital systems rather than people. On the other hand, the Swedish response generally has been quite good, apart from that mistake, right? So, for instance, there were some mass gathering limitations, but most of what happened was voluntary. They would tell people, here's who is a higher risk. And so they organized these community responses where like neighbors would deliver groceries to older people living in their neighborhood. They involved the community in mitigating the risk as much as possible. They asked people to stay, if you can stay home from work, fine. If you have to go to work, you go to work. They didn't try to like imperiously do shelter in place orders, mandatory business closures, and they never closed schools for kids at 15 and under, not once. And children during spring 2020, no children died, even though they didn't close schools during the height of the worst part of the pandemic. And the teachers actually had lower death rates than the average of other workers in the population. So it's one of these things where like the voluntary the way that they used public health was essentially like in cooperation with the public. They asked for voluntary cooperation from the public, and they got it because they treated the public like adults. Another example of like I think a much more reasonable policy, like South Korea was a little more reasonable. There's parts I didn't like. I didn't like the overweening contact tracing applications. There was too much emphasis on that. But like early in the pandemic, they didn't close businesses, they didn't close schools. They were much more reasonable. Again, trying to like involve the public in their response more effectively. The Florida response, I think, was pretty good. I mean, the key thing there was focused protection of older people, because they have such a large fraction of older population. They do a lot to try to protect nursing homes. Not perfectly, because this is so highly infectious. It's hard to keep things out. And especially, but what I really liked was early when the vaccines came out in December 2020, Governor DeSantis called me and asked me for advice about who to vaccinate, and I suggested prioritize older people. And by the end of January 2021, every person in the nursing home in Florida had a vaccine offered to them. I think every person over the age of 65 had a vaccine offered them very rapidly. My mom, living in LA, didn't get her vaccine until like late March 2021, whereas every person in Florida had one offered. An older person had been offered the vaccine by January 2021. It's peaked out lower than I would have hoped, but it's still that early vaccination effort focused on older people was the key thing. Was saved many lives, I think. I think generally places that Scandinavia generally had much less emphasis on school closures. Europe generally has much less emphasis on school closures. The Chinese example is just a tragic example, right? This zero COVID policy has devastated the lives of so many Chinese people, with human rights abuses on a vast scale, and it failed. It failed to keep the disease out, just as you predicted it would fail to keep the disease out. There's still a lot to learn from the various countries. It's impossible in a short time to like cover it in any detail. And of course, there's particulars about every single country that which would leave it, like I could think of a theoretical approach how you would manage it. That's what the Great Barrington Declaration was in a short one-page document. But it's always going to be local. Right, focus protections would always be a local thing. So people sometimes would say, "Well, how do you do focus protection?" There's no one answer. It's going to be very different in South Central LA than it will be in Billings, Montana, than it'll be in Stockholm. The key thing is the focus on protecting the most vulnerable. That's the key idea, and then not harming the less vulnerable with draconian policies that don't actually stop the disease from spreading. I mean, those would have been the two principles. And to the extent that countries follow those two principles, I think they did better.
Let's say there's another pandemic of some kind, and I guess the question is, what would it look like in order to justify something like a full lockdown for some period of time? What would the infection fatality rate have to be? What kind of bug would we be talking about if it justified in your mind something like a lockdown?
I mean, I think the key thing is not the infection fatality rate, but the predictors of high risk, and then our knowledge of transmission. Right. So if you have like there's this irony, right? So if you have something that's very, very highly transmissible, lockdown is not ever going to work. There's just a useless, harmful thing. I can imagine something that has transmitted uh, by 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 fomites or something that doesn't have very strong person to person transmission, where local lockdowns might be useful. So, for instance, like I think in the polio epidemic, there'd be local closures of schools when the disease was being in high. I mean, it'd be very short duration, right? So that's focused. It's children that are high risk. You know that the disease is being transmitted at high rates right now. They didn't fully understand that it was fecal oral transmission then, but they would close schools to reduce the amount of spread of it. I could imagine a justification around that, but the school closures were very short in duration. It wasn't years. And they certainly didn't close schools in anticipation of a vaccine coming for years. So it has to be would have to be balanced. I can't imagine a situation where I would ever support a full lockdown for an extended period of time, because that would always lead to more harm than good. Like if you had a high IFR disease, it's going to cause deaths. It's unfortunate. There's nothing, and let's say we have no way of mitigating it, right? You have to accept that that's a fact. The key thing is who's most vulnerable, even with a higher IFR disease. You can still identify who's the most vulnerable, who's least vulnerable, and ask people who are the least vulnerable to keep society going. Because if you just shut them down, also you'll end up causing more harm than good. I don't think a lockdown of the kind we used should ever be used again. I frankly think it should be a dirty word. I think we should shudder in horror when we think about the harms, the extent of harms it caused to the poor, the vulnerable in the world. I can't imagine a disease that could be mitigated by it, whereby the marginal benefit from it would actually outweigh the marginal harm in terms of the lives lost from them.
Given what we've been talking about and how much of a bummer some of the stuff can be, I want to ask you more of a positive question, more of an open-ended question. What are you most hopeful or optimistic about in terms of the future of our society in general?
Despite the problems that we've seen with the application of science, I actually think there are a lot of good things. Like it's amazing to me how the scientific community came together to try to address this problem. A lot of really talented people put their minds to this, and a lot of advances happen as a result, right? I mean, the vaccines being one of them, although I think they were misused and caused a lot of social harm. Biologically, I think is quite an achievement. So I do think that I'm actually quite hopeful that if we can put the right structures in place, there's a lot of good that can come out of science. And we've seen that during the pandemic. So to me, that's quite hopeful. The other thing I think has been healthy, although it's been painful, I think, for scientists, is people now have a much better understanding of what science actually is than they did. Like I think most people who have been thinking about things now understand that scientists aren't gurus. We're not omniscient. We don't know. What we are people that are just curious about how the material world functions, and we do experiments to try to understand it. And it's slow and halting. The fact that people understand that science is this human thing. It's not this like the Spock-like thing, and we somehow learn about the world just by our sheer intelligence. And that it's inaccessible to everybody. Now people understand science affects them, and that people understand that they can understand science, at least at some level, and maybe even participate in it. I'm hoping that out of this pandemic will come a generation of kids who are interested in science, and that science is transformed into something that's much less authoritarian and much more participatory, much more democratic, much more so back at the roots of the Enlightenment, where it seemed like everyone on the face of the earth who wanted to participate in science could do so.
All right. Well, Dr. Jay Bhattacharya, thank you very much for your time. I know you've been busy recently, so I appreciate you sitting down with me. Are there any final thoughts you want to leave people with, or anything you want to reiterate from our discussion?
Nick, I'm really grateful to be able to talk with you. I've been looking forward to it for a long while, and I hope this doesn't get taken down from YouTube. So YouTube folks, we're actually trying to just do honest science here.
All right. Thanks, Jay.
Take care.
This episode is supported in part by the Amino Company. They specialize in making science-backed amino acid products that you can mix into any drink. Their products contain a mixture of essential amino acids, the building blocks of proteins in the body, as well as other nutrients including minerals like iron and electrolytes like potassium. Your body is constantly repairing damage, and your muscles and tissues need the right mix of amino acids and nutrients to do this effectively. One thing I like about Amino Co. is they actually conduct clinical trials to determine what their products really do. They have a variety of formulations engineered for different purposes, and my personal favorite is one called Heal, which has been shown to be 3 times more efficient at triggering muscle growth and repair than other protein sources. It helps maintain healthy inflammation levels and preserve muscle mass during periods of inactivity. I mix this product into the water bottle I bring to the gym and consume it before, during, and after my workouts, and I have felt a noticeable difference in my performance during those workouts and my recovery times from soreness and fatigue afterwards. Their products are keto-friendly, soy-free, vegetarian or vegan, gluten-free, and non-GMO, so they are compatible with almost any diet or lifestyle. You can support the podcast and try Heal or any of their other products by using the discount code MIND when you visit aminoco.com/mind. You will get 30% off your purchase. If you work out regularly or do intensive exercise, I recommend trying AminoCo's products. I get a lot of companies reaching out to me about advertising, and I only end up using and liking a small percentage of the products that I see. So check out aminoco.com/mind and use the code MIND to try these products today for 30% off.